Hello, my name is Cheryl Fitzgerald and I'm one of the medical consultants in the Department of Reproductive Medicine. I'd like to welcome you to this presentation, which is the first part of your IVF treatment pathway. IVF treatment is complex and involves many different steps. We hope that this presentation will help you understand what is involved in preparation for your clinic consultation. We are a large multidisciplinary team in the Department of Reproductive Medicine, including administrative staff, nurses, doctors, counsellors and scientists, and you will come into contact with many of us during your treatment. Please ask for help and advice whenever you need. We are all here to help and support you every step of the way. During the presentation, we will outline what happens in a typical IVF cycle, as well as explaining some of the risks and problems that may occur. At the end of the presentation, we will tell you what will happen next to enable your treatment to start. One of the most common questions that patients ask is how many cycles of treatment am I allowed within the NHS? And we will be able to give you information about this in your clinic consultation. The number of NHS-funded IVF cycles we are allowed to offer is determined by your clinical commissioning group, your CCG. These groups make decisions about the funding of healthcare for their individual populations. The guidance around eligibility varies between CCGs, and your eligibility to treatment can also change over time, for example as the female partner ages. The decision to start an IVF treatment cycle will depend firstly on your clinical situation. Will the treatment give you a chance of a successful pregnancy? If so, we will also have to confirm that you are eligible to start that individual treatment cycle within the NHS. Eligibility has to be in place at the start of each individual treatment cycle. So, for example, a couple who may at this point be eligible for 3 cycles may not be able to complete those cycles if the female partner undergoing treatment turns 40 after her first or second cycle. We appreciate that this information may seem confusing, and we can answer your individual questions about this at your clinic consultation. If you have a baby from an IVF cycle, you will not be eligible for any further NHS-funded treatment. Therefore, if you have frozen embryos in store following your cycle and you wish to use them, you would need to fund that treatment yourself. You can fund that treatment here at St Mary's, or if you prefer, you can transfer your embryos to another unit. If you do not have a baby and have frozen embryos in store, they can be replaced as part of your NHS-funded cycle. We are only able to offer NHS-funded treatment to patients who fulfil the eligibility criteria laid down by their CCG. If you want to know further details about the specific criteria for your CCG, please contact them individually or contact your GP. Before talking about IVF treatment, we need to talk about the implications of coronavirus. You will be aware of the risks facing each and every one of us from coronavirus. Coronavirus can affect anyone. Our understanding at present, from the scientific evidence that we have, is that pregnant women are at the same risk as everyone else. Currently, we do not think that coronavirus poses a greater risk to women when they are pregnant. There is also no evidence at present to suggest that babies are more likely to suffer from abnormalities if the mother has coronavirus whilst pregnant. However, this strain of coronavirus is new, so our knowledge of it is increasing with time, and therefore we cannot say for sure that there is no increased risk. We also know that if a woman develops a high temperature from any cause, there is an increased risk of miscarriage. Therefore, some patients may wish to delay their treatment until this outbreak is over. Please let us know if you wish to delay. Unfortunately, at present, we do not know when the outbreak will be over, and it is possible that this may be a very long time. If this is the case, we cannot confirm that we would be able to treat you after, for example, if your clinical situation or age had changed. At all times, safety, both for patients and staff, is our top priority. Please ensure that you read the information sheet that you will receive about the implications of coronavirus on treatment and pregnancy. You will be asked to sign that you have read and understood the guidance before starting treatment. We will ask you to confirm that you have no symptoms of coronavirus before you start your treatment cycle, as well as taking a swab. As you will understand, our policies respond to changing advice, so we will discuss the exact screening procedures at the start of your treatment, and it may be that we need to take a swab on more than one occasion. If a suspicion of coronavirus arises during treatment, we will have to cancel your cycle. In these situations, we would contact your CCG to ask permission to offer you a further cycle of treatment, but the decision to allow further treatment would lie with your CCG. It is important that you do everything that you can to reduce the risk of coronavirus infection during your treatment. Where possible, please self-isolate from the time that your treatment starts until you have carried out your pregnancy test. To reduce risk, we ask female partners undergoing treatment to come into the department on their own, unless you have a specific need to be accompanied, which must be arranged in advance. Please wear non-medical face coverings when in the department and maintain social distancing from staff and other patients whenever possible. As well as coronavirus, there are other infections that can cause risk in pregnancy. These include Zika, Ebola, trypanosoma, malaria, and others. If you have travelled to areas where these diseases are endemic, your treatment will be delayed, even if you have not suffered from the disease. Risks from infections change with time, so we would urge you to follow the advice given by the Foreign and Commonwealth Office and Centre for Disease Control. If you have any concerns, please ask during your clinic consultation. There are two types of IVF treatment, although the term IVF is commonly used to cover both. In IVF, sperm are added to an individual egg, and the process of fertilization happens in a similar way to fertilization in a natural cycle. In ICSI, an individual sperm is selected and placed inside the egg using an injection needle. When we examine sperm, we look at the number of sperm present and also examine for the way the sperm is moving, the motility, as well as checking the percentage of sperm that look normal under the microscope, the morphology. When any of these parameters are reduced, we use ICSI to assist fertilization. In your consultation, we will discuss whether we feel we should use ICSI in your particular treatment. There are three main stages in IVF treatment. The first stage involves stimulating your ovaries to encourage the development of several eggs, whilst at the same time ensuring that the secretion of hormones from your pituitary gland, a small hormone-producing gland in the brain, is controlled in order to prevent eggs being released prematurely. The second stage of IVF treatment involves collecting eggs from the ovaries and mixing the eggs and sperm for fertilization. After fertilization, we allow the embryos to develop in incubators in the IVF laboratories, looked after by our scientists, the embryologists. During embryo development, the embryologists will check on the embryos and choose which embryo or embryos should be replaced, as well as the best day on which to replace. The third stage of treatment involves giving additional hormone support during the luteal phase after embryo transfer. We will tell you which date to do your pregnancy test and ask you to let us know the result. We obviously hope that the test will be positive, but sadly for many patients it is not, so we will also help you deal with the outcome of your test and support you through this time as you need. There are two main types of IVF stimulation protocols, and we use both here at St Mary's: the agonist or long protocol and the antagonist or short protocol. Both stimulation protocols encourage the development of several eggs in the ovaries, whilst also stopping their release prematurely. In the majority of cases, using either the long or short protocol will not significantly affect the response of the ovaries, but there are specific situations where the use of a particular protocol has been shown to improve outcome. The long protocol has been shown to give better outcomes for women with endometriosis, and the short protocol is particularly useful in women where we expect a high response to stimulation and worry about an over-response. In your consultation, the doctor will explain which protocol we feel is better for you. We will now look a little more closely at what happens in both treatment protocols. In an agonist protocol, we ask you to contact the unit on the first day of your period. Once you are accepted for treatment, we ask you to abstain from intercourse or use condoms. We will ask you to start injections of a drug called buserelin from about a week before your next period. The injections are very small needles and are placed just under the skin. The nurse will teach you how to deliver the injections, and either you or your partner can give the injections. This injection of buserelin switches off the drive to your ovaries and hence temporarily stops your ovaries working. When the ovaries are switched off, they stop producing the hormone estrogen, so you may notice some side effects from lack of estrogen, such as hot flushes or mood swings. These side effects are temporary and will settle after the second drug to stimulate the ovaries is started. We ask you to contact the nurses when your period starts, and we will then arrange for you to come into the unit a few days later. When you come to the unit, we will check your hormone levels to confirm that the injections of buserelin have been effective. We will then ask you to start an additional injection of follicle-stimulating hormone, or FSH. This second drug encourages the development of several eggs in the ovaries. During this time, you will also continue with the injections of buserelin to ensure that the eggs are not released prematurely. You will continue to have both injections daily until your scan shows that the follicles in your ovaries containing the eggs are large enough for us to advise your trigger injection. With the antagonist protocol, we will ask you to start injections of FSH when your period starts. On day 5, we will ask you to add a second injection of the antagonist, which is called cetrotide. You will then continue with both injections daily until the day of your trigger injection. As I said when describing the stimulation protocols, the ovaries are stimulated with a hormone called follicle-stimulating hormone, or FSH. There are various trade brands of FSH, but their effects are very similar. We will teach you how to give all of the injections that you need, and there are clips which you can watch via our website for reference. After 10 days of stimulation, we will ask you to attend the unit for a transvaginal ultrasound scan, which will look at the response of your ovaries. Many patients are ready for their trigger injection that day, but if not, we will arrange for further scanning visits if necessary. Occasionally, we will also need to take a blood test, and if this is the case, we will discuss this with you. Response to FSH injections is very variable. In your consultation, we will discuss the dose of FSH that we feel is appropriate for you. This is decided mostly on your ovarian reserve test results. Your baseline ultrasound scan and blood level of anti-Müllerian hormone, AMH, give a good indication of the reserve of eggs within the ovaries, and we will tailor your treatment to that. Whilst we aim for several eggs to develop, we must also do everything we can to reduce the risk of an over-response. Although your ovarian reserve markers are a good indicator of how you should respond to stimulation, sometimes the response is not as we would expect. Very occasionally, we will suggest altering the dose of FSH following your day 10 scan. When your scan shows that the follicles within the ovaries are the correct size, we will ask you to have a trigger injection. We use 2 types of trigger, HCG, often called Pregnil, or if you have an antagonist cycle, we may decide to use buserelin. The type and dose of trigger will depend on the protocol that you are on and your response to stimulation. There is a window of a few days in which the trigger can be given without affecting success rates, but once we decide the day of trigger, the exact time at which the trigger should be given is crucial, as we want this to be given approximately 36 hours before you go to theatre for your egg collection. The trigger injection is needed to mature the eggs, and we will arrange the time for you to go to theatre to maximise the chance of mature eggs being collected, whilst minimising the risk of the eggs being released before theatre. Your egg collection will take place approximately 36 hours after your trigger injection. On the morning of the egg collection, you will be admitted to the ward in the IVF unit. You must starve for several hours before the procedure, including not drinking or chewing gum. The nurses will tell you when you need to starve from. It is important to starve as the anaesthetist will give you sedation during the egg collection. There will be several people in theatre for your egg collection. Each member of staff has an important role in ensuring that the procedure runs smoothly for your safety. The egg collection is a relatively quick procedure, taking 20 to 30 minutes. After the egg collection, you will be monitored for a short time, and you will usually be able to go home about 3 hours later. You will need to be collected from the unit by an adult. The egg collection is carried out under ultrasound control. A transvaginal ultrasound probe is used to locate the ovaries and the follicles in the ovaries. The ultrasound picture on this slide shows what the doctor carrying out the egg collection will see. Follicles are filled with fluid and are seen as dark areas on scan, as you can see in the upper image. A needle, which can be seen as a bright echo in the upper image, is passed through the top of the vagina into the ovary and into each follicle in turn. Eggs grow within the fluid in the follicles and are withdrawn as the fluid is aspirated. Not all follicles contain eggs, so the number of eggs retrieved will almost always be fewer than the number of follicles. In rare circumstances, we may retrieve no eggs, even though we have seen a good number of follicles on scan. If this is the case, we will arrange an urgent consultation to discuss your treatment cycle. You will know how many eggs were retrieved before you leave the hospital after your egg collection. As you have received sedative drugs for your egg collection, you must not drive for 24 hours, and you must have somebody with you at home overnight. You can take paracetamol and codeine if you have pain. It is normal to notice some pain after an egg collection, but please contact the unit to let us know if the pain is not controlled or if you start to feel unwell in any other way. The nurses will be able to assess your symptoms on the phone and will ask you to attend the hospital for further review if they have concern. You will start using progesterone pessaries twice daily from the morning after the egg collection. These pessaries are usually inserted vaginally, but can be used rectally if you prefer. On the day of the egg collection, male partners will be asked to attend to produce a sperm sample if fresh partner sperm is being used. There are rooms in the department available in which you will be asked to produce the sample. If you think there may be a problem in producing the sample, please tell the doctor at your consultation. We ask you to abstain from ejaculation for 2 to 5 days before producing the sample to allow the best quality sample to be produced. Abstaining for a longer period does not increase sperm quality and in fact usually reduces quality. The scientists in the laboratory will process the sperm sample. In some cases, the sample produced may be poorer than previously, and we may suggest changing to ICSI to aid fertilization. Very occasionally, we may ask you to produce a second sample. If there is going to be a change in treatment or the need for a second sample, one of our embryologists will come to see you to explain why and what this entails. Depending on the quality of the sperm sample and your previous history, we will use either standard IVF or ICSI for fertilization. In your consultation, we will discuss with you the method we feel should be used to give you the best chance of a successful pregnancy. If previous sperm samples have been normal, we will suggest IVF. But if the sperm sample on the day of egg collection is of poorer quality, one of our scientists will see you to suggest changing to ICSI. After eggs are collected, our scientists examine each egg to look for signs of the eggs being mature. Not all eggs will be mature. This is what we expect. ICSI can only be performed on mature eggs, as immature eggs will not fertilise normally, either with IVF or ICSI. On average, about 2/3 of eggs will fertilise, but as this is an average, the number of eggs that fertilise will vary for different patients. In rare cases, none of the eggs retrieved fertilise, and we realise this is devastating for couples. If this is the case, our embryologists will speak to you in the first instance, and we will arrange an urgent clinic consultation. This slide shows what a normally fertilised egg looks like. At this stage, the embryo is still a single cell, but contains 2 pronuclei, which are the small genetic packages, one from the egg and one from the sperm. This is what the embryologists see under the microscope on the day after the egg collection. Any embryos that look like this, i.e. have fertilised normally, will be put into the incubator to culture further. About 1/3 of eggs will not fertilise or will not fertilise normally. This image shows an abnormally fertilised egg. As you can see, it does not contain 2 normal pronuclei. Eggs which do not fertilise normally cannot go for further culture as they will not develop normally. These eggs and embryos will be allowed to perish. Before they perish, however, they can be used either to help train new embryologists or they can be used for research. We have a very active research programme looking at the best ways to help couples with fertility problems and looking at the long-term health of babies conceived after IVF treatment. In your consultation, we will ask you about your wishes for any eggs, sperm or embryos which cannot be used for your treatment, and whether you would like these to be used as part of our training or research programmes before they are allowed to perish. In your consultation, you will be asked to sign a consent form to reflect your wishes. Here at St Mary's, we use time-lapse imaging within our laboratory when we feel that it will help in the selection of the best embryo or embryos for replacement. This clip shows the early stages of embryo development using time-lapse. On day 1, a normally fertilised egg is seen with 2 pronuclei. Later on day 1, these pronuclei fuse before cell division to create first a 2, then a 4-cell embryo on day 2. On day 3, embryos should have divided to 6 or 8 cells. The quality of the embryo is indicated by the number of cells, whether the cells are the same size, and whether any fragments are seen in the embryo. On day 4, there is further cell division and what is described as compaction. At this stage, we cannot clearly look for signs of embryo quality, so do not replace embryos on day 4. By day 5, the embryo is starting to develop into a blastocyst, with cells starting to develop into different cell lines with different functions. The outer layer of cells developing into the placenta, the afterbirth, and the inner cell mass becoming the fetus and eventually the baby. If you have many good quality embryos, we will select the best quality embryo to put back as part of the fresh cycle, but we'll be able to freeze others that are of good quality. Only embryos of good quality will be frozen, as only these will give a chance of a pregnancy in the future. Embryos can be frozen for up to 10 years, unless there are exceptional circumstances which are defined by law to allow extended storage. In your consultation, we will ask you if you want embryos to be frozen if there are suitable embryos to freeze, and we'll ask you to sign consent for this. Not all patients will have embryos suitable for freezing. In some cases, we may suggest freezing all embryos after your cycle, rather than proceeding with a fresh transfer. We may suggest freezing all of your embryos if we are concerned that continuing to a fresh transfer could increase the risk to your health. Sometimes we find something during your treatment which can affect the chance of embryos implanting, and in these cases we will also discuss freezing your embryos to allow any further treatment necessary to increase the chance of pregnancy. Although the majority of embryos will survive the freeze-thaw process, sadly not all will. Your embryo transfer will be carried out under ultrasound guidance, but for transfers we use transabdominal ultrasound rather than transvaginal, so we will ask you to drink to fill your bladder beforehand. Embryo transfers are similar to a smear test, so no pain relief is needed, and you can go home directly after. You may have heard of embryo glue. This is a specific type of medium that the embryos are placed into before embryo transfer and has been shown in clinical trials to improve the chance of embryos implanting. Therefore, we use this for all of our embryo transfers here at St Mary's. Our embryologists will advise whether 1 or 2 embryos should be replaced, and this will depend on many factors, but the decision is mainly driven by embryo quality. Our aim is to replace a single embryo, as replacing 2 embryos increases the risk of a multiple pregnancy. And unfortunately, multiple pregnancies carry significantly higher risk, both for mother and for babies. After your embryo transfer, you will be advised to continue with the progesterone pessaries that you started the day after your egg collection. We will tell you the date on which to perform your pregnancy test. Please continue with the pessaries until the day of your pregnancy test or until we advise you to stop. If the pregnancy test on the date that we have told you is negative, you should stop the pessaries. If the test is positive, you should continue with the pessaries until you have your ultrasound scan, which confirms an ongoing pregnancy. If you miscarry or your scan shows a miscarriage, you should stop the pessaries. After your embryo transfer, you can continue with normal activities, but we advise that you avoid strenuous exercise. This slide shows our results from 2018, showing the number of pregnancies following every fresh embryo transfer. The results are from 2018, as patients who had treatment at the end of 2018 will have delivered their babies late in 2019. At St Mary's in 2018, 35 to 36% of women under 38 years who had an embryo transfer had a live birth. As you can see, this chance reduces in older women. The slide also shows the chance of a live birth for every embryo replaced, rather than per embryo transfer procedure. This slide shows our results for frozen embryos in 2018. The chance of a live birth per cycle and per individual embryo is lower than in fresh cycles, as would be expected, as we choose the best quality embryos to replace in fresh cycles. However, if you have embryos frozen, there is a 1 in 4 to 1 in 5 chance that a frozen embryo transfer cycle will lead to a live birth. We will now talk about some of the risks associated with IVF treatment. For patients treated with the long protocol, some women will experience some side effects from the buserelin. This drug can cause hot flushes, mood swings and headaches as a result of the reduction in ovarian hormones produced during buserelin treatment. Occasionally women will develop cysts when treated with buserelin, but in the vast majority of cases, these will resolve spontaneously. One of the main problems that we encounter during IVF treatment is a poor response of the ovaries to stimulation. As women grow older, the number and quality of eggs in the ovaries reduces, so a poor response is more likely in older women. Before your treatment starts, we assess your ovarian reserve by measuring the level of anti-Müllerian hormone, or AMH, in your blood, and this gives a good indication of your reserve and how your ovaries will respond to stimulation. However, sometimes, even when we expect a good response from AMH levels, there is a poor response of the ovaries to stimulation. Occasionally, we can try to overcome this by increasing the dose of FSH used for stimulation, but often there is no alternative other than cancelling the cycle. If there is no response to ovarian stimulation, we will discuss the option of using donor eggs in further treatment if you wish. At the opposite end of the spectrum, some women are at risk of over-response to ovarian stimulation. From your ovarian reserve tests, we will decide the optimum dose of FSH to try to elicit the best response from your ovaries, without risking over-response. But unfortunately, OHSS cannot always be predicted, and approximately 2% of women having IVF treatment will develop the syndrome. In some groups, such as women with polycystic ovaries, the risk is higher. Ovarian hyperstimulation syndrome is a serious condition that occurs following an excessive response by the ovaries. This causes swelling and discomfort associated with nausea and sometimes vomiting. Patients who develop the condition may also complain of shortness of breath and passing only small volumes of urine. It is important that you are aware of these symptoms and contact us if you develop them. If you develop symptoms out of hours, please contact either the emergency gynecology unit or the gynecology ward for advice. No surgical procedure is risk-free, and although the likelihood of a problem after an egg collection is low, some women may develop an infection or suffer from bleeding. If you have any concerns about any symptoms after your egg collection, please contact us so that we can advise you about any further investigation or treatment. There is evidence that babies conceived following IVF ICSI treatments are more likely to be affected by congenital abnormalities than babies conceived spontaneously. The cause of these remains unclear, but are probably more related to the cause of the couple's subfertility than the treatment itself. It is important to stress that the vast majority of babies born after IVF and ICSI are normal. There is also evidence that babies born after IVF and ICSI treatment are more likely to be born early and tend to be small for gestational age compared to spontaneously conceived babies, although babies from frozen embryo transfer cycles tend to be larger. Although ultrasound is used to place the embryos in the correct place in the womb, sometimes embryos can drift into the fallopian tube, and the risk of ectopic pregnancy after IVF is higher than that in spontaneously conceived pregnancies. This is a higher risk for women who are known to have tubal damage. Once again, if you develop any concerning symptoms, please let us know. The biggest risk after any type of IVF treatment remains that of multiple pregnancy. Unfortunately, multiple pregnancies carry significantly higher risks for both the mother and the babies. Professional bodies have developed strategies to help reduce the risk of multiple pregnancy without compromising the overall chance of pregnancy. We work using these guidelines and your individual risk factors to decide how many embryos to replace to give you the best chance of a healthy baby. Unfortunately, at every stage of human development, there are losses, and IVF treatment is no different. Not every follicle contains an egg. Not every egg will be mature. Only 2/3 of eggs will fertilise, even with ICSI. Not all embryos will develop normally, and not all embryos will survive freezing. Additionally, with IVF treatment, due to the nature of eggs, sperm and embryos and the need for complex manipulation of the cells within the laboratory, sometimes we may describe them as being lost or not surviving the laboratory processes. This is unfortunately a well-recognised and accepted risk of assisted conception treatment. Fertility treatment can be very stressful for couples, and we would urge you to contact our counsellors for support if you feel that they can help at any stage. This may be before, during or after treatment. Counselling is completely confidential, with the counsellors holding their own separate notes, so you can discuss anything you wish with them. Some couples will be asked to see the counsellors as part of their treatment, for example if they're going to use donated eggs, sperm or embryos, so that they are fully aware of the implications of those treatments. We may also arrange a counselling appointment if there is anything in your history to raise concern about the welfare of a child that may be conceived from treatment. If you are referred to the counsellors to discuss welfare of the child concerns, the counsellor will need to discuss the issues raised in counselling with the clinical team to confirm that treatment can proceed. We are part of a large NHS trust and have close links with the University of Manchester. We have a very active research programme with our main research interests lying in the best way to treat infertility and the long-term health of babies conceived after fertility treatment. As you go through your treatment, you will be able to be involved in research projects if you wish, and you may also decide to allow any eggs, sperm or embryos which are not suitable for clinical treatment to be used in research before they are allowed to perish. The decision whether to participate in any of our research projects is completely yours. Our research nurse can speak to you during your treatment to discuss ongoing trials. IVF treatment is strictly regulated by the HFEA, the Human Fertilization and Embryology Authority. You can visit their website and it contains lots of information that you may find useful. The HFEA has very strict guidelines about the consent processes surrounding IVF treatment, and consent forms need to be completed by both partners before any licensed treatment can start. A copy of these forms will be provided to you before your consultation. Please familiarise yourselves with the forms so that you are able to ask any questions at your consultation. We are currently introducing an electronic process, and we will inform you about the process that you will follow. You can vary your consent at any time, up to the point of actual treatment. This is particularly important to remember if you have frozen embryos in store and your situation changes in the future. If you have any concerns or if your situation changes, please let us know in writing so that arrangements can be made to alter your consent. An appointment for your consultation will be sent to you. If the appointment time is not suitable, please contact our office to rearrange. Please read through the HFEA consent forms and think of any specific questions that you may have before the consultation so that you can get the most out of your consultation. If you are having treatment as a couple, both parties will need to attend the consultation. Most couples will have a video consultation, but we may need to arrange to see some couples face to face. At the consultation, we will need to confirm your identity, so we will need a passport-size photo from both partners before treatment, and we will confirm your identity from your passport or driving licence. We will finalise your individual treatment plan, sign the relevant consents and answer your questions. We hope that this presentation has helped you understand what IVF treatment involves in preparation for your consultation. Please remember that we're all here to help you through every step of the way. And finally, I'd like to wish you all the very best of luck.